Dear students, now the present topic is on a large ball and socket joint in our body, that is about the hip joint. So hip joint, it is a synovial joint, and under synovial it is a ball and socket joint. So here is the anterior view of the hip joint showing the head of the femur articulates with the acetabulum of hip. So here the hip joint is exposed showing the articular surfaces. So first we shall do the articular surfaces. We can see the head of femur which articulates with the acetabulum of hip bone. So acetabulum of hip bone, and the head of the femur, it is covered by an articular cartilage which is the hyaline cartilage except at the fovea capitis. So except here fovea, where we can see an attachment of ligament attaches to the fovea capitis which is called as the round ligament. So except at that point, rest of the head of the femur is covered by hyaline cartilage. Acetabulum presents a horseshoe shaped lunate articular surface. So here is the lunate articular surface except at acetabular fossa and acetabular notch. So this point, so this area, so except acetabular fossa and acetabular notch, the rest of the acetabulum which makes the lunate articular surface which articulates with the head of the femur to form the hip joint. So the stability of the hip joint, so the factors providing the stability of the hip joint, preventing it from dislocation. So we can see the acetabulum is quite deeper and narrow from its mouth by acetabular labrum. And there are three strong ligaments associated with the hip joint called as iliofemoral, pubofemoral and ischiofemoral joint, which strengthens the capsule of the joint. And strength of the surrounding muscles like gluteus medius, gluteus minimus, other gluteal muscles are the muscle surrounds the hip joint, protecting the joint from anterior and posterior aspect. And if you see the length and the obliquity of the neck of the femur, so if you see the length and the obliquity of the neck of the femur, which also is a factor responsible for preventing the hip joint. So it is a factor providing the stability of the hip joint. So let's move on to the ligaments of the hip joint. So the common ligament which is present with all synovial joints is fibrous capsule. So the fibrous capsule attaches to the acetabular margin of the hip bone. So here is the fibrous capsule which attaches to the acetabular margin and acetabular labrum and transverse acetabular ligament. So that is the So this is the proximal attachment, and on the femur the distal attachment is to the femur. So it is along anteriorly to the intertrochanteric line. So intertrochanteric line to the anterior side and posteriorly 1 centimeter in front of the medial to intertrochanteric crest. Posteriorly, here is the intertrochanteric crest. So 1 centimeter medial to the intertrochanteric crest is the posterior attachment of the fibrous capsule. And it has got two types of fibers. inner circular fibers which are called as zona orbicularis fibers and outer longitudinal fibers which are reflected along the neck towards the head to form the retinacula. The synovial membrane lines the inner aspect of the fibrous capsule. The intracapsular portion of the femoral neck, glenoid labrum, both the surfaces, and transverse acetabular ligament, ligamentum teres, and the fat of acetabular fossa. So all these are enclosed within the fibrous capsule of hip joint. So next, moving on to the second ligament, that is iliofemoral ligament. So we know the hip bone has got three parts: ilium, ischium, pubis, and the ligaments are from the three parts: iliofemoral, ischiofemoral, and pubofemoral ligament. So we shall begin with the iliofemoral ligament, which is called as ligament of Bejelot. So iliofemoral ligament is otherwise called as ligament of Bejelot, and it lies anteriorly and blends with the capsule. And if we see this ligament, it is almost like inverted Y shaped, where the apex is attached to the lower half of the anterior iliac spine. So this is anterior superior iliac spine, and here is the anterior inferior iliac spine. So it attaches here in the lower half of the anterior inferior iliac spine, and also to the acetabular margin and base of intertrochanteric line. So if you see, it goes to the base of intertrochanteric line. So almost like inverted Y-shaped structure. It has got three parts: a lateral thick oblique fibers. So the lateral fibers are thick oblique fibers. So this is the lateral thick oblique fibers, and a medial thick band which is called as the vertical band, medial thick band of vertical fibers. So this is the medial thick band of vertical fibers, and central large thin portion. So here this is the central large thin portion, and it is the strongest ligament of the body. So iliofemoral is the strongest ligament of the body and prevents the trunk from falling backwards in standing posture. It also prevents hyperextension of the hip joint during standing. So the next ligament is the pubofemoral ligament, so which is attaches from the pubis here. So pubofemoral ligament reinforces the fibrous capsule inferiorly, and it extends from the pubis bone to the femoral neck and limits abduction, also the extension. So it attaches to the femoral neck here, these fibers, which attaches to the femoral neck deep to the iliofemoral ligament, and it strengthens the femoral capsule from inferior aspect. Okay, the next ligament is the ischiofemoral ligament. It supports the capsule posteriorly, and it is attached to the ischium bone. So here is the ischium bone. We can see the attachment, and it attaches behind the femoral neck to attach to the greater trochanter. So we can see from the ischium, from posterior aspect, attaches to the greater trochanter. So this is, and this is the ischium. So this ligament is ischiofemoral ligament. So it attaches to the greater trochanter deep to iliofemoral ligament. Okay, next we move on to ligamentum teres, which is also called as the round ligament. round ligament or ligamentum teres of the head of the femur. Actually, it is like a flat triangular ligament with the apex attached to the fovea of the head. So here is the apex attached to the fovea. This is the fovea of the head. And its base to the transverse acetabular ligament. So this is the transverse. So we can see here it blends with the transverse acetabular ligament. It carries the acetabular branches of obturator and medial circumflex femoral arteries. So we can see the branches, arteries here, which are the circumflex femoral arteries. So branches of circumflex femoral arteries it carries to supply the head. Next, about the acetabular labrum. Acetabular labrum is a fibrocartilaginous rim attached to the acetabular margin to deepen it. So along the margins of the acetabulum, the ligament which attaches is the basically deepens the acetabulum. It deepens the depth of the acetabulum, preventing the head from dislocation. So acetabulum is a fibrocartilaginous rim which is along the margins of the acetabular cup, and it is to deepen it, and its transverse acetabular part bridges the acetabular notch. So here, so it transverse acetabular part, we can see it bridges the acetabular notch. Next, about the transverse acetabular ligament. Transverse acetabular ligament bridges the acetabular notch, and the notch is converted to a foramen to transmit the nerves and the vessels to the hip joint. So here, so the transverse acetabular ligament bridges the acetabular notch, and it converts this notch into a foramen to transmit nerves and vessels to the hip joint. Next, we would look upon the relations of the hip joint. Anteriorly, hip joint is related to iliacus and psoas major muscle, pectineus, straight head of rectus femoris, sartorius, femoral vein, femoral artery and nerve, femoral nerve that is. These are the structures which are related anteriorly. Posteriorly, the hip joint is related to obturator externus, quadratus femoris, obturator internus tendon with two gemelli, that is obturator internus with superior and inferior gemelli together forming a tricipital tendon. And posteriorly, hip joint is also related to piriformis, which is the key muscle of the gluteal region, gluteus maximus and sciatic nerve. Superiorly, the hip joint is related to gluteus minimus and medius, straight head of rectus femoris. And inferiorly, hip joint is related to pectineus, obturator externus, gracilis, adductor longus, brevis and magnus. So these are the relations of hip joint. Let's move on to the blood supply of hip joint. So beginning with the arterial supply, hip joint is supplied by medial and lateral circumflex femoral arteries, obturator artery, superior and inferior gluteal arteries. They also supply the head of the femur, but arterial supply of the head and neck of the femur is chiefly derived from the medial circumflex artery. These are the retinacular arteries which run along the neck of the femur through retinaculum of the capsule. So if you see here, we can see the longitudinal retinacular arteries which run along the capsule, retinaculum, that is the central part of the capsule of the hip joint. So, and also one thing we have to note here, the nutrient artery of the femur gives few branches to the neck and head of the femur as well. That is, the obturator artery is the nutrient artery, the branch of obturator artery which supplies the head as well as the neck of the femur. Moving on to the nerve supply, as we know, anterior compartment of the thigh is supplied by femoral nerve. So femoral nerve, where through the nerve to rectus femoris. So the nerve to branch to the rectus femoris, same nerve supplies the hip joint also. And anterior division of obturator nerve. So we know the obturator nerve is the nerve of the medial compartment of the thigh, which also supplies the hip joint from medial side. Nerve to quadriceps femoris, superior gluteal nerve, sciatic nerve. From posteriorly, superior gluteal nerve and sciatic nerve supplies the hip joint. So if we see the spinal segments, 4 consecutive spinal segments, that is L2, L3, L4, L5, all 4 consecutive spinal segments control the movements of the hip joints, as like L2 and L3 regulate flexion movement, adduction and medial rotation. So L2, L3 regulates flexion, adduction and medial rotation, whereas L4 and L5 regulate the extension, abduction and lateral rotation. So this is how the spinal segments are responsible for each movement of the hip joint. Let's move on to the bursa which surrounds the hip joint. There are totally around 7 bursa related to the hip joint. So 4 out of these 7, 4 are under the gluteus maximus muscle and 1 is under the gluteus medius and 1 under the gluteus minimus and 1 is under the psoas tendon muscle. So let's discuss a few of them. So first one is the trochanteric bursa, which is present between the gluteus maximus and greater trochanter. So trochanteric bursa is between the gluteus maximus and greater trochanter. Ischial bursa. Ischial bursa is between the gluteus maximus and ischial tuberosity. Gluteofemoral bursa, which is between the gluteus maximus again and vastus lateralis muscle. So it is between the gluteus maximus and vastus lateralis. Subpsoas bursa, as the name suggests, it is associated with the psoas tendon. So it is between the iliopubic eminence and psoas tendon. So it is called as subpsoas bursa. It communicates with the synovial cavity through the gap between the iliofemoral and pubofemoral ligaments. Next we shall discuss about the weaver's bottom, where the subgluteal bursa, that is bursa which is between the gluteus maximus and ischial tuberosity, it is frequently gets inflamed and enlarged in the people whose profession requires a long periods of sitting. Example, weavers who sit for a longer time. So here the subgluteal bursa will get inflamed and causing a inflammatory bursitis, that is inflammation of subgluteal bursa, leading to a clinical condition called as weaver's bottom. So let's move on to the movements and the main muscles and accessory muscles which produces the movements at the hip joint. As the hip joint is a multi-axial joint, it has the movements like flexion, extension, abduction, adduction, medial rotation, lateral rotation and circumduction. So beginning with the flexion, the main muscles which are causing the flexion of the hip joint are iliacus and psoas major. Accessory muscles are sartorius, pectineus are the accessory muscles, and also the rectus femoris is also an accessory muscle which causes flexion at hip. Next about the extension. Extension, the primary muscles are only 2 sets. We can say gluteus maximus, which is a powerful extensor of hip joint, and hamstrings. All the 4 hamstring muscles, which are the posterior compartment thigh muscles, help in the extension of hip joint during walking. And gluteus maximus extends the hip during climbing and fast running. Moving on to adduction and abduction. Adduction is caused by adductor muscles, that is adductor longus, adductor brevis, adductor magnus. And accessory muscles are pectineus and gracilis. So pectineus and gracilis are accessory movements which bring adduction. Next, the abduction. Abduction is caused by gluteus medius and minimus muscle. They are the primary abductors, and along with the gluteus medius and minimus, TFL, tensor fasciae lata, and sartorius also causes abduction. Next, about medial and lateral rotation. First, about medial. Medial rotation is brought by gluteus medius and minimus, and also TFL, tensor fasciae lata. So these three muscles will cause medial rotation. Lateral rotators are the short muscles, which are called short lateral rotators altogether. So the short muscles are obturator externus, obturator internus, and two gemella, that is superior gemellus, inferior gemellus, and quadriceps femoris. All these are short lateral rotators of hip joint, and accessory muscles are piriformis, sartorius, and gluteus maximus also brings lateral rotation of hip joint. So the important points which you have to remember here, the strongest flexor of the hip joint is iliopsoas muscle, and hip flexion is done by sartorius, pectineus, and rectus femoris also. And iliofemoral, which is the ligament of Bejelot, it forms an inverted Y-leg, which is the strongest ligament of the hip joint, and it limits the hyperextension and prevents the trunk to falling back. Next, about Langenbeck's triangle. In Langenbeck's triangle has an apex at anterior superior iliac spine of the ilium to the greater trochanter and surgical neck of the femur. So if this forms the base, so the base is between the greater trochanter and surgical neck of the femur forms the base, and apex is at ASIS, that is anterior superior iliac spine. So if there is any penetrating wound in this area, it likely to involve the hip joint. So that is the importance of Langenbeck's triangle. Let's see the other applied aspects also. Dislocation of hip. The dislocation of hip may be the posterior, which is the most common dislocation. Anterior is less common and central is least common. So the sciatic nerve is injured in posterior dislocation of the hip. Congenital dislocation, CDH, that is congenital dislocation of hip, or CHD. So the congenital dislocation of hip joint is more common than any other joint in the body. So hip joint congenitally often dislocates. It occurs due to two reasons. That is, the joint capsule is loose at birth, that is one reason. Second is hypoplasia of acetabulum and head of the femur. So because of the hypoplasia of acetabulum and femoral head, in this condition, the head of the femur slips away upwards into the gluteal region, and because of the upper margin of the acetabulum is developmentally deficient. Clinically, it presents like inability of the newborn to abduct the thigh, and affected limb is shorter in length and externally rotated. Asymmetry of the skin folds of the thigh is also observed. So you can see here in the image, there is asymmetry of the skin folds of the thighs. And as the baby starts walking, we can see the lurching gait. Lurching gait with a positive Trendelenburg sign. So these are the symptoms which you identify in congenital hip dislocation. So acquired dislocation, of course, it is uncommon, but it may occur during an automobile accident when the hip joint is flexed, adducted, and medially rotated from the usual position of the lower limb when one is riding a car. So in this position, the joint is unstable because the head of the femur is covered posteriorly by the joint capsule and not by the bone. So that is unsafer position, and during head on collision, the knee strikes the dashboard. So if there is a car accident, that is dashboard injuries, the knee strikes the dashboard and dislocates the hip joint posteriorly. So the knee as it goes, we see the posterior dislocation of the hip joint. So the head of the femur is forced out of the acetabulum by tearing the capsule. So postero-inferior, the capsule gets torn postero-inferiorly and lies, the head lies along the lateral surface of the ilium in posterior dislocation. So this causes the shortening of the limb and also the medial rotation of the affected limb. So we can see the limb gets medially rotated and the length also compared to normal side, the length get reduced. So there will be limb shortening. The next condition associated with the hip joint is 𝐒𝐲𝐫𝐢𝐬, means the neck shaft angle is reduced from normal angle. So what is the normal angle? The normal angle is 120 to 130 degrees in adults and 150 to 160 degrees in children. So often the neck shaft angle is reduced due to the fracture of neck of the femur. So for example, in Perthes disease, this deformity is called as 𝐒𝐲𝐫𝐢𝐬. If the angle is increased, that is congenital dislocation of hip, it is called as 𝐒𝐲𝐫𝐢𝐬. So 𝐒𝐲𝐫𝐢𝐬, this deformity may also occur due to Perthes disease, softening the neck due to rickets. Let us discuss on this Perthes disease or pseudocoxalgia. It is characterized by the destruction and flattening of the head of the femur, and it occurs usually between 5 to 10 years old children. And as we see in the X-ray, so it shows the increased joint space in the X-rays. So that is the identification feature. Flattening of the head is observed in Perthes disease. Next, about the osteoarthritis of the hip. It is a disease of old age, osteoarthritis, and it is characterized by the growth of osteophytes at the articular ends and erosion of articular cartilage, which not only limits the movements but also makes rough and painful. So due to repeated wear and tear, it may cause osteoarthritis of the hip joint, where in chronic conditions it needs to be replaced. So it is called total hip replacement or partial hip replacement. Moving on to the referred pain of hip joint. In the diseases of hip joint such as TB, tuberculosis, the pain is referred to the knee joint because of common nerve supply of both these joints. So these two joints have got a common nerve supply. So any disease in the hip, the person also complains of pain in the knee. Next, the fracture of the neck of the femur. The fracture often associated due to indirect violence of trivial nature. The person falls down and cannot get up. So the affected limb is much shortened and it is laterally rotated. So the diagnosis is generally confirmed by taking an X-ray. 𝐒𝐮𝐬𝐜𝐫𝐢𝐻𝐿 line in a radiograph of hip joint we can represent by a continuous curve. So all of you observe this. It is just like a continuous curve formed by the upper border of obturator foramen and lower margin of, that is the lower border of neck of the femur. So upper border of obturator foramen and lower margin of the neck of the femur, they are in line, making one curved line which is called 𝐒𝐮𝐬𝐜𝐿 line. This curve is disrupted. It gets disturbed in the fractured neck of the femur or dislocation of hip joint. So this is all about the applied aspect and normal anatomy of hip joint. Thank you.